Yeah, so smoldering myeloma is such a controversial area because the patients, basically it's a heterogeneous disease. You have some patients who will progress very fast to multiple myeloma and some who may never progress, who are MGUS-like. And it's really a question, how can we differentiate when you're sitting down with a patient on who will progress and who will not, and can you make a decision to go on a clinical trial at that time point? We have clinical markers, which we call now the 20-20, 20% cancer cells in the bone marrow, 2 grams protein, 20 light chain ratio, but they may not be enough to really stratify our patients in a very careful way and truly give them that personalized risk stratification. And some of the things that I talked about today were about, can we use dynamic models, something we call Pangea, because we bring the whole world back together, and we're trying to use that dynamic models of the M spike going up, the light chain going up, your bone marrow percentage increasing, your hemoglobin is decreasing. That gives you a chance of telling the patient you are really going towards myeloma and let's consider some therapy. And then the other ones is, can we improve on it? Can we talk about biology? We have genomic changes, meaning if you're having chromosomal aberrations, if you have certain mutations, that will probably put you at risk that the cells are growing faster. So can I be more smart in defining those rather than using FISH in the bone marrow? And we showed that indeed when you do whole genome sequencing of circulating tumor cells, that can give you a sense of who will progress faster or not. And we developed a myeloma-like genomic model. And then of course, nothing can happen without the immune environment. So if you look at the tumor cells and the immune system, can you put them all together and really understand the risk of progression?